do physical examination. First, the overall appearance, facial expression, diaphoresis pair, and degree of agitation. And then inspection for scars, hernias, and masses. Then palpation is the most critical step. You will find tenderness, rebounding pain, and rigidity and guarding. So I know maybe 2 weeks ago you have learned the gastric ulcer, the proportion of gastric ulcer. So for this kind of disease, you will. Did you touch this kind of borderline abdomen? No experience. So today I have asked today's doctor in duty. I asked the doctor if you have some perforation of ulcer, just keep it in the emergency. Because after all, our students will touch it, will do a palpation. He said, okay. So maybe you're lucky to see this kind of patient. Okay. So normally, the right upper area and the left upper area, the left lower area and the right lower area, the 4 regions, different organs, different disease, and different manifestation, and different pain, different kinds of pain in nature. For organ injury, you will know the incidence, different incidents. For example, spleen is the most susceptible to be injury. And the second is kidney, then liver, stomach, colon, retroperitoneal organs. So if the patient feel pain at this area, so you will know how many you should recall in your memory suddenly how many organs in this area, and so you will check. You see the patient and you're thinking. This is the area for liver, right kidney, gallbladder, pancreas, and colon. And for this area is also left liver. Left kidney, spleen, pancreas, the body and the tail of the kidney, the body and the tail of the pancreas and the colon. For this area, colon, small intestine, and ureter and appendix, and for this area. For this area is actually this area is many organs, easy to be injured or inflammation. So for this area is difficult to diagnose. And for this area, left lower part, is, if some patients ask the doctors, I know just intestine. Intestine is major causes of colon is a major causes.
Excuse me, Professor?
Mm-hmm.
Why didn't you consider the stomach and the left upper quarter?
Stomach?
Yeah.
Yeah.
You didn't consider.
Yes, you are right. No stomach?
No stomach.
Did you see stomach? So the stomach will move. And if the stomach, for example, if stomach gastric ulcer, maybe 1 or 2 centimeters perforation, and the patient will feel severe sudden pain, the upper abdomen, no exact site. And then if the gastric fluid flow to other sides, so maybe 30 minutes or 1 hour later, the patient will feel the peritonitis, the whole abdominal is very, so for this kind of patients, if you went to emergency department, the doctors only touched borderline abdomen. Diffuse the peritonitis.
In the colon.
Yeah, colon.
Which part of the colon? Is it the transverse colon?
Transverse colon.
You know, the incidence of organ injury from the circulatory.
What does it mean? You mean this area? Or the whole?
No,
The
the
whole colon?
that's last slide.
The highest incident of organ injury is spleen, right?
Mhm.
Spleen, and then we
Yeah,
have
yeah,
kidney, liver, stomach,
Yeah.
and the colon.
Yeah.
Because ascending and descending is also in the peritoneal organ.
Okay, I know. Because the colon is very long, you want to know which part
Yeah, is
will
it
be
the
more easily. Most part easy to damage.
Is it
Yeah. So in my experience, actually, this area and very close to the rectum is dangerous to be damaged. And this is another side, is the transverse. I mean for injury, just trauma, injury, not inflammation. So we will do auscultation. You will find a hyperactive BS or sound, or hypoactive BS or silent BS, according to different inflammation and different reason. Then percussion. You can do a digital examination of rectum. It's a routine part of the physical examination. And you can check for problems with organs or other structures in the pelvic and the lower area. It's very important, but in my experience, many young doctors, they don't do it. So I always ask young doctors to do it. It's very important because some young doctor reported some patient to me, oh, this is a special patient because we found the abdominal pain not very severe, and we also found some multiple lesions, small lesions in the liver. I will immediately ask this doctor, did you do a digital examination for the patient? Because maybe sometimes it's colorectal carcinoma with metastasis to the liver. Okay, and then in physical examination, you can do diagnostic abdominal puncture. For me, my experience, if I get a telephone call, it says emergency patients need assistance, I will go to the department of the emergency. And then I will take needle with me. If I go to the patient, just go to the bed, I will immediately do it, very, very quickly. Okay. So, for example, we will do this McBurney position. And actually, if you're finishing an examination, which part of area is the most pain? The patient complains of pain. This area, sometimes you can do the puncture, but it's dangerous for the intestinal obstruction patient. So you should do it carefully. If you think about this kind of abdominal pain may be related to the formation of stomach or the rupture of solid organ or some small intestine, rupture of small intestine, you can do the puncture. But if you think about this diagnosis would be maybe intestinal obstruction or other disease, you don't need to do it. It's dangerous. So I will ask you, if the patient because amylase increased maybe 600 units, and abdominal pain and the ultrasonography tell us, demonstrated a little bit ascites, fluid collection in the abdominal cavity. So what do you need to do the puncture? Is my question to you.
No.
Why? I mean, pancreatitis. You don't want to do it? And the ultrasonography has demonstrated the fluid collection not in the peripancreatic region, just in the whole abdominal side. Yeah, acute. You're right. Okay. Yes, because for pancreatitis, the patient will fail. Not the pain site is not very exact. I mean, maybe it's the whole abdominal pain. So it's very difficult to differentiate it from other maybe other disease. But if the ultrasonography found some ascites, not in very close to the pancreas, the other sides, you can do it. The first is helpful to find some important fluid to do the examination. If the fluid amount is very high, normally 2,000 units, strongly indicating severe pancreatitis. And if you puncture from the bloody fluid, so it might be the necrotizing pancreatitis. And but if you found a patient moderate pain and ascites, and you do puncture, you found just a mild bloody fluid, and the laboratory finding showed increased amylase in the fluid, and you puncture the fluid. So, but you don't get no CT scan, maybe at night, no CT scan to confirm the pancreatitis. I know you know CT scan is the golden standard for diagnosing pancreatitis. So, but at night you don't have a CT scan, maybe. I mean, enhanced CT scan. So you have to think about another disease. So do you know which kind of disease you should think about? The first is pancreatitis, and the second, mild bloody fluid and high amylase level in the fluid. That's it, positive. Okay, for this patient, you have to think about colon, the tumor carcinoma of colon. Okay, so for some special patients suffering colon tumor, colon carcinoma, adenocarcinoma, so also with ascites and with high. Okay. So this.
How do you perform this function?
Yeah, I think you did it. Maybe, do you have any experience?
No.
Yes. Second affiliated with paracentesis study.
So how do you perform it?
To remove the cytic basis, this was that.
First, you have to check. You have the first step is you will determine is this patient suitable for puncture? You will first step.
But you go in directly, you said it's very.
Yeah, yes, it's dangerous. For some special patients, you don't need to do it. You have to make a decision. Is it safe or effective for me to do it?
And you
The
are
first.
doing this puncture mainly for diagnosis.
Yeah, yes. And the second step, you will which site to do the puncture. First, yes, this is the normal site or McBurney site. You can do it. For every patient, you can do it. No doctors will say, oh, you are wrong. No doctor will criticize you. This is a normal site. And if you give ultrasonography to the patient, and So you will, according to the result of sonography, according to the result of ultrasonography, the fluid collection, so you will do the puncture.
So where do we collect the fluid from?
What pattern? Where?
Yeah.
Why?
No, where do we collect the fluid from? In the peritoneal cavity?
Yes.
But most of the colon is retroperitoneal. So how do we know that it's like
Yes.
ascending, descending, and
Yes. Yes.
and
there are
most of the colon?
two reasons. Two reasons. So first is ultrasonography. The second is just palpation. And because if for some borderline abdomen for gastric ulcer recuperation, according to your clinical experience, you have to puncture. If you get some food, sometimes you get food puncture, and some dirty intestinal fluid. So you will make a decision. But the primary diagnosis is operation or rupture of gastric gut. This is the liver, left liver rupture, and this is the intestinal rupture. So the laboratory found you will find the WBC increased, and you will check the differential counting, the total the leukocytes count, and the percentage of polymorph nuclear cells are usually elevated in acute inflammation conditions. And whereas early in the course of intestinal obstruction, there may be no significant alteration. The urine analysis, blood in the urine, suggests the disease of urinary tract and can also result from an inflamed appendix lying proximity to the artery, urethra or bladder. In dehydration, specific gravity of the urine may be increased, and the red cell and the hemoglobin values also increase. And for amylase and lipids, serum amylase value in excess of more than 500 units are significant, and levels of 1,500 to 2,000 units or more are most unusual in the early stage of severe acute pancreatitis. And therefore, we have to keep it in mind, HCG, because if you next class we will learn appendicitis and it's for some young lady with acute abdomen. You have to check it, HCG, the human chorionic gonadotropin, because you know it. Yeah. Okay. It's secreted by the placenta and secreted to the blood of the mother, and the level will increase to the peak about 8 weeks after pregnancy, and then decrease gradually. So it's very sensitive for detect early pregnancy. Okay, and then you will check bilirubin, ALT, AST, and AKP. The imaging studies. First is standing X-ray and the QUV. And for solid organs, you can use ultrasonography. CT is very important, but it's limited. Its use, the CT use is limited in different situations. For example, in some local hospital, there's no CT scan, and for big hospital, maybe at night, no CT, no. If we ask the radiology department to do CT scan at night, the doctors from radiology will tell us, we have doctors, but we have no nurse. Nobody will do the drug infusion for you, enhanced CT scan. So no nurse. We don't provide enhanced CT scan. So it's very, very difficult for our surgeon to make a decision. No CT scan.
So in emergency condition, why can't the doctors inject the enhanced?
Sure. Also, actually, the doctor could do this work, but there's some regulation. There's some certain regulation. The doctor do something, the nurse do other things. Sometimes the department of radiology will say, "Oh, please take a nurse from the department of emergency to help us to do it." But the nurse in the emergency department, we don't want to go to. So if we call, so the surgeon, finally the surgeon will call the chief of radiology department, and the professor will make a call to the nurse, and the nurse will come from the family room at night. Maybe half an hour or 1 hour, we will do CT scan. We can do, but we have to ask. CT scan of abdominal organs and visual vessels is probably important already at the beginning of the diagnostic workup, especially for some special disease. For example, some solid for some patients, for example, the liver rupture for hepatocellular carcinoma. We found it's obvious to find the fluid, the blood collection. We know the blood comes from the liver. The diagnosis is confirmed. But if the diagnosis is related to hepatocellular carcinoma, so it's very, very difficult for doctors to make a decision. If we open the abdominal cavity, if the tumor is very large, how could I do? If the tumor couldn't be resected, it's unresectable. So how could we control the bleeding? So we have to do CT scan to make sure whether the tumor, the hemorrhagic tumor, could be resected.
If suppose the tumor is too large that you can't resect it, so in that case, what will you do to stop the bleeding?
Yeah, yes. But so at my hospital, we have to do CT scan for bigger operation to check it.
No, if suppose the tumor is large enough that you can't resect it.
Yeah. So what can we do
to stop the bleeding?
To stop bleeding? So we will discuss the next slide maybe. Okay. So, but do you have any treatment option to provide to me? If we know after CT scan, we know it's a big tumor, unresectable, but it's consistent bleeding. The blood pressure is just okay, just so. Maybe half an hour, the blood pressure will decrease significantly. So, how could we do the next step?
You can block the main blood supply for the tumor.
Infusion? Yes, infusion. We don't stop infusion.
That is important. We'll stop the main blood supply for the tumor. We'll locate the main blood vessel that is providing the tumor and block it from the beginning so that the tumor will not get the blood anymore.
Tumor embolization.
Very good. Thank you. So you are smart.
Thank you. Smart.
Okay. Then angiography. You see, not the next, just this slide, angiography. Because before we do blocking the vessel, penetrating the tumor, we to provide the blood supply to the tumor. So we had to do angiography to check the vessel, is it right? To check the vessel and block it. So this is a gastric ulcer. This is a urethral calculus. Okay. And this is pneumoperitoneum. And this is intestinal obstruction. Cholecystitis. There's inflammation. Inflammation ring around the gallbladder. You see it? So hypodensity. And lower density means water, means edema. And this also edema, you see, is effusion. pancreatitis. So this is pancreatitis related to cholestasis. So how we do? How can we do the next step? Because you see, we don't find many ascites, many fluid, just some fluid or effusion or fluid, just a little bit fluid collection, very close to the pancreas. So we couldn't do puncture. We couldn't do drainage, surgical drainage. So what's the next step to do if you see this patient?
Blood test.
Mm-hmm.
Blood test.
Blood test is maybe just 10,000.
Anti-inflammatory.
A little bit increased.
So you mean diagnostic procedure or the treatment?
No,
Yeah.
diagnostic.
So
Diagnostic procedure.
you will make a decision to do medical treatment or do operation. If we found some stone in the common bile duct, we also will open the common bile duct to take the blood, and we'll put a tissue to drainage the bile to bile. And for pancreas, we nothing to do. This is one way. And the second way is if after 1 week treatment, the fever increased, and we found we did a repeated CT scan. We found a necrotic and high fever, maybe 39 degrees for 5 days. The renal function has been decreased. So what will dysfunction, renal dysfunction appear? So what will be the next step?
Dissect the pancreas.
Operation.
Dissect the pancreas.
Second.
Yeah.
Right there.
Supportive therapy.
We will do emergency operation. The first to resect the gallbladder, and the second to drainage, to open the membrane, the pancreas membrane, and take the necrotic, take the inflammation fluid, infected fluid, and put a drainage, put a good drainage, and sometimes we will take necrotic tissues, the clothes.
Not dissect the whole pancreas?
Mm-hmm.
The whole pancreas.
No, just necrotic partial.
Excuse me, sir.
Mm-hmm.
Before, when we were discussing about collection of fluid in acute peritonitis, and you said that amylase level is also high and there's pancreatitis, and because of that also the patient had peritonitis and amylase level was very high. But in some cases, like we could not find pancreatitis, so we will consider tumor of the colon.
Yeah.
So in that case, we can also consider this polycystitis with